In this lecture, we will discuss the ST segment and T wave, including what they represent, how they normally appear, and how they are often affected in myocardial ischemia. The ST segment represents the plateau phase, or phase 2 of the cardiac action potential. It begins at the junction point, or J point, to the onset of the T wave. Because the plateau phase has a long duration, most of the ventricular myocardium can contract simultaneously. In addition, because the potential is relatively unchanged during the plateau phase, the potential differences in the myocardium will be small during this phase. And therefore, the ST segment should normally be isoelectric at the same level of the baseline, or PR segment. Okay, so again, just to define, our ST segment is from our J point. So notice our J point is this point here at the end of our QRS complex, and then it goes up until the beginning of our T wave. So here's, imagine our J point there, and this would be here. So highlighted in green, this region there is our ST segment. Okay, and we said that the ST segment occurs during this plateau phase, which is phase 2. So this is our plateau phase. Okay, and imagine this is our contractile cell, its action potential. This is our EKG recording, and we're seeing that during phase 2 we have this ST segment. Okay, and normally during that plateau phase is that we don't have much, relatively unchanged potentials, electrical potentials, and because of that, the ST segment tends to be flat. Okay, remember when we define baseline, our baseline is here. Imagine here's our PR segment. So if we had a P wave here, this would be our PR segment. That usually defines, and that's what we use as our baseline, okay, to see if there's any elevation or depression. Now, the transition from the ST segment to the T wave is normally smooth, just like the transition between phases 2 and 3 of the action potential. However, this transition will be abrupt during ischemia, okay? So if we look here, here's the transition between phases 2 and this is 3. We have a smooth transition between our ST segment and our T wave there. And we said that oftentimes during this, in a ischemic event, all right, the EKG will see more abrupt changes between those phases 2 and 3, and that will show changes between our ST segment and T wave being more abrupt in nature. Okay. Now we know that the T wave represents rapid ventricular repolarization, okay, which is phase 3 of the action potential. Normally it should be concordant with the QRS complex, such that the main QRS vector should be followed by a T wave in the same direction. Here's a list that we have here of the normal T wave direction in multiple leads. Okay, so again, what we mean about concordance, here's our QRS complex. Notice that it's mostly positive, its main vector, and here's our T wave. Notice that it's again upright and mostly positive. Okay, so normally we should see that. So again, normally concordance with our QRS complex in most leads. Remember, this is phase 3. This is phase 3 that represents that ventricular repolarization phase of our action potential. And now we have a list of leads here, 1 to negative AVR. So negative AVR, if you had AVR here, negative AVR would mean this case here, this one here. Okay, and then we're saying leads 1, leads 2, V5, and V6. So all these leads should have an upright T wave, okay? And obviously if negative AVR has an upright T wave, AVR, which is right here, as it moves away from that lead, should have an inverted T wave inversion in that lead. In lead 3, you can have possibly an isolated T wave inversion. And this is normal if there's no T wave inversion in lead AVF. Remember, lead 3 sits in this region here. In AVL, okay, which is a high lateral lead, you can possibly have isolated T wave inversion. In AVF, you often have upright T waves, but sometimes they can be flat. Remember, AVF is right here at positive 90 degrees. Okay, in V1, you can have T wave inversion, but remember, these T waves will be concordant with our QRS complex, okay? So meaning if our T wave is inverted, we'll have mostly a negative QRS complex, okay? You may see a small R wave here, but it'll be mostly a deep S wave, okay? Concordant with our inverted T wave. Or you can see a flat T wave is also common. This is especially common in females. In the posterior leads, V7 through V9, you'll see upright T waves. So these are all normal changes that you can expect to see with our T waves. All right, now because phases 2 and 3 of the action potential are related, changes to the ST segment will also affect the T wave. These changes between the J point to the end of the T wave are commonly referred to as STT changes. So we've been saying that STT changes are what we call these, okay? So let's look at these STT changes that occur during ischemia. Myocardial ischemia affects the plateau phase, phase 2, and rapid repolarization phase, which is phase 3, and therefore is why ischemia causes these STT changes. We learned that the ST segment can be elevated or depressed in relation to the PR segment, while the T wave may be diminished or increased in amplitude or even inverted. The changes that we see in the ST segment and T waves depend on the timing, localization, and extent of the ischemia. If you recall, when we measure the ST depression or elevation, we must use the baseline as our reference line. And the reference line that we use as baseline is the PR segment. From that reference, we use the J point as the area of this ST segment that we measure as ST elevation or ST depression. In other words, if the J point is above baseline, it would be considered ST elevation. If the J point is below baseline, then it would be considered ST depression. Now, sometimes and rarely, the PR segment is difficult to discern or make out, and therefore the TP segment, which is the line between the T wave and the P wave, can be used as a reference, okay? So just so you're aware, when we measure our ST elevation or depression, we're looking at the J point, okay? And that's this point, J point here, is that here in red, okay? So you can see there's our J point. Okay, and we're saying that we measure in reference to our PR segment. Here's our P wave, okay, our PR segment, or PQ segment, okay, either one. This is what we use as our baseline. So if you imagine that's our baseline, you can see that this J point is elevated above it, okay? And if we use this PR segment as our baseline, you can see that this J point is below, so we call that ST depression. So ST elevation and ST depression. And what I said is if you can't make out that PR segment, which is rare, we can use what we call the TP segment. Okay, and the TP segment is the line between the T wave and the P wave. So imagine here's our P wave, and you have a preceding T wave, okay? You can use this segment between it, which is called our TP segment, as your baseline, okay? Now, what we use today is the PR segment. You'll hear a lot of people say otherwise, but recent studies have suggested that the PR segment should be used, okay? And there's many reasons that we won't get into around that, okay? Now, sometimes the J60 point is also suggested to be used, okay? Such as in the setting of exercise stress testing. So just so you're aware what the J60 point is, that's this one. Let me just erase some of this here so you can see. Okay, it's that here in yellow. Okay, that's J60 point, and it's this point here, 60 meaning 60 milliseconds after the J point. So our J point counts 60 milliseconds after. This is something we can use, okay? And again, that's in yellow here and this point here. And this is usually used in exercise stress testing. So just something so you're aware of if you hear about it. All right, let's briefly review what we discussed before we end. So remember, the ST segment is from our J point, okay, to the T wave onset. It's normally at baseline, and remember, baseline we defined as our PR segment. It represents phase 2, that plateau phase of the action potential. The STT transition, we said normally should be smooth. It represents the transition between phases 2 and 3. If there's more of an abrupt, that's seen more in ischemia, okay? Now the T wave, we said, is normally concordant, going in the same direction as our QRS complex in most leads. It represents phase 3, all right, that repolarization phase. We mentioned a number of normal ways and variants in which we can see the T wave that are listed there. You can keep them handy or as reference. The STT changes, remember these represent changes between our J point, okay, our J point here, and our T wave. So this region here, okay, we consider our STT changes. Now in myocardial ischemia, remember this affects phases 2 and 3, so this region here, okay, and because it affects those phases, that's where we see these STT changes. The ST segment can be deviated up or down, meaning ST elevation, as we saw here, or it could be depressed, okay, and then we said This J point is what we use as our reference to measuring ST elevation or depression, okay, from the PR segment, okay? We said the TP segment can be used if we can't make out the PR segment very well, okay? But oftentimes you can use that PR segment. And then that J60 point, 60 milliseconds after the J point, that's usually used in exercise stress testing. The T waves can be flat, they can be inverted or increased in amplitude, like in hyperacute T waves, okay? And then remember, these STT changes really depend on the timing, localization, and extension of the ischemia. Well, that's the end of this lecture. We discussed the ST segment in T-wave, including what they represent, how they normally appear, and how they are affected in myocardial ischemia. I hope you learned something.